lead the Medicare Beneficiary Quality Improvement Project, or MBQIP. I want to thank Allie Orwig with the Indiana Rural Health Association for helping today with some Zoom platform support and making the webinars possible and very smooth. All lines are muted, but please feel free to unmute by clicking the microphone button on if you have any questions at any time, or chatting in your questions in the chat box. And we've had several hospitals have turnover in quality staff and been working with individuals on just their role in quality, understanding all of the initiatives, and just helping with making some improvements on the various MBQIP measures. And so we wanted to provide some quality improvement education overall. And sometimes it's just nice, even if you've been in quality for a while, to have just a little bit of refresher and hear some of the information over, or maybe hear some information that maybe you've forgotten. So in developing the education, I connected with Sarah Brinkman, who's with Stratis Health. She's the program manager there. And Stratis Health, as you probably know, or many of you know, they're the national support contractor for the MBQIP program. And they have some excellent videos and resources, as well as they provide some quality education as well. So we wanted to take advantage of Sarah's knowledge and expertise. Sarah has a very strong background, and her specialty is quality improvement. She also does some grant writing and strategic planning, as well as program development and implementation. She's worked with a multitude of teams across the country, and even within some of the rural communities, and Stratis Health is just a real promoter of rural health and healthcare and providing access to rural communities. So I'm going to turn the presentation over to Sarah. The presentation was sent out yesterday around 11:20 for those that just joined, if you'd like to pull that up for reference and be able to take notes. And so, Sarah, I'll turn it over to you.
Great. Thank you so much. And thanks for having me back. It's this is a great group to work with. So some of you have heard me present before. And for those of you who haven't, I will let you know I'm a very informal presenter. I prefer for things to be interactive if at all possible. I think you learn more that way. I know I learn more that way. It makes it a lot more enjoyable than just listening to my voice over and over. So please do weigh in. Feel free to unmute yourself. Feel free to use chat. I'd love to hear your feedback as we go through things today. So we're going to talk about the Medicare Beneficiary Quality Improvement Project, or MBQIP, and a quality improvement overview. So straight away, there is acronym soup all over this, this first slide. And we always like to acknowledge that when we're talking about quality improvement and MBQIP and all of the quality reporting programs, there's a lot of acronyms involved. If I say something that you don't know what it means, probably there are others who don't either, and so certainly ask me, with the caveat that sometimes I don't remember what the acronyms stand for, but I can tell you what the general meaning is. So please do stop me. We try as hard as possible to write things out when they're introduced the first time, except for in this title slide, but if I missed anything, please let me know. Okay, so I've been here before. I'm back again. I'm great to be here. Becky did say that I work with Stratis Health. We're an independent nonprofit based in Minnesota. We work really at the intersection of research, policy, and practice, with a focus on driving quality improvement and improving patient safety. We have a long history of working with rural providers. There are 78 critical access hospitals in Minnesota, and we are a Minnesota-based organization. But more recently, we've really expanded to be national in scope in a lot of the technical assistance that we provide, and we serve as the Rural Quality Improvement Technical Assistance Center for the Federal Office of Rural Health Policy. So as Becky mentioned, that basically makes us the National Technical Assistance or Coordinating Center for the state offices of rural health that work on the FLEX program, the Medicare Rural Hospital Flexibility Program. So your state FLEX program receives funding from the Federal Office of Rural Health Policy. We receive funding from them as well, and then work closely with your state FLEX programs. And from time to time have the opportunity to work directly with critical access hospitals, either through providing this type of education or technical assistance requests that might make their way to us. Our objectives today, we are going to not spend a ton of time on the first couple objectives here, but do want to call them out. We want to understand the purpose and the importance of critical access hospital participation in the Medicare Beneficiary Quality Improvement Project and identify what the requirements are for MBQIP participation. I know that Becky reviews that with you all. We just want to kind of do some level setting before we jump into reviewing the foundational concepts and some of the support resources that are available for you all as you're implementing quality improvement at your facilities. So, an overview of MBQIP. MBQIP comprises the quality improvement activity that state flex programs are funded for to support their work in their states under the Medicare Rural Hospital Flexibility Grant. So again, the state flex programs receive funds from the Federal Office of Rural Health Policy, and then they get to work with you all as critical access hospitals to implement the activities that they submit for. Quality improvement is one of the required activities. So state flex programs are required to work with their hospitals on quality improvement. The Medicare Beneficiary Quality Improvement Project, or MBQIP, has become a standard way for them to do that. And the reason that that's so important is that it gives the Federal Office of Rural Health Policy the ability to demonstrate improvement over time in rates of reporting and performance on measures. So prior to MBQIP existing, state flex programs worked on quality improvement with their critical access hospitals, but every state did it different. And in some cases, states did it different with every single hospital. They still have the flexibility of how they implement the program and the type of support services that they offer. So this would be an example, this webinar is an example of a group technical assistance and education opportunity for you all. You may have one-to-one conversations with Becky or others from the State Flex program. You may have site visits. You may do different things in different ways, but there is a standard set of measures that have been identified that all critical access hospitals are asked to report on in order to participate in the Flex program. And that really gives the Federal Office of Rural Health Policy a huge leg up in being able to demonstrate impact in a way that they weren't prior to this program existing. So the goal here is to improve the quality of care that's provided by critical access hospitals, first by increasing quality data reporting and then driving improvement activities based on the data. Some of you may come from facilities or be part of health systems that have that are required to participate in quality reporting as part of their Medicare status. So if they're a prospective payment system hospital, or if you've worked at one in the past, you know that PPS hospitals first were asked to report voluntarily, then there was pay for reporting, then they started to get paid for their performance. Critical access hospitals, by virtue of how they are paid by CMS, have never been required to participate in those CMS quality reporting programs. So over time, those quality reporting programs that PPS hospitals have participated in have really gotten them ready for the value-based purchasing environment. So it's really helped them to be able to demonstrate the quality and the value of the care that they provide and allowed them to start to think about their care provision in a different way as we move from fee for service to pay for performance and value. Critical access hospitals were potentially being kind of left in the lurch without being required to participate in those CMS programs. And so the Federal Office of Rural Health Policy identified that gap and developed MBQIP as a way to be kind of a stopgap to help hospitals report on a set of rural relevant hospital metrics. So that's really important. There are a lot of measures that PPS hospitals report on that simply are not relevant to critical access hospitals based on the types of services that they provide. But they wanted to find what those rural relevant metrics were and strongly and provide the services and the support and resources needed to get critical access hospitals reporting. And then they are providing technical assistance, encouragement, support by way of your state flex programs, by way of the Rural Quality Improvement Technical Assistance Center at Stratis Health, through other partner agencies like the Flex Monitoring Team, which takes a look at quality reporting and provides it to us in a variety of different ways. As much as possible, the federal office has attempted to align the metrics for MBQIP with federal quality programs. What this does is allows us not only to see how are critical access hospitals doing on a particular measure nationwide, which is amazing that we have the ability to do that in and of itself, but we can also see how are they doing in comparison to their PPS counterparts, because many of the measures that are part of MBQIP are also required measures for PPS hospitals under their quality reporting programs. It also allows us to leverage the quality reporting mechanisms that exist already and that are supported through federal agencies like CMS or the CDC. So for the Centers for Disease Control, we use the National Healthcare Safety Network for a couple of our measures. For the Centers for Medicare and Medicaid Services, CMS, we use QualityNet and their data warehouse for many of the measures. So that allows us to leverage those already existing processes. It also helps critical access hospitals get familiar with those data repositories and processes, so that if they are ever required in the future to participate in CMS programs, they know how to utilize them and they're ready to go. So in a really simplified manner, what we're looking at here is that we want to improve patient outcomes. So in order to improve patient outcomes, we have to improve the quality of the care that's provided. And then the adage in quality is that if you can't measure it, you can't improve it. So similar to some of you who maybe come from nursing, if you didn't document it, it didn't happen. If you can't measure it, you can't improve it. So the very first step is to make sure that we have quality measurement in place. With the goal of improving those patient outcomes. Secondary to improving patient outcomes for rural communities, we wanted to, again, help critical access hospitals prepare for that value-based environment. How can critical access hospitals demonstrate the value of the care that they provide if they're interested, for example, in joining an accountable care organization, if they don't have quality metrics to be able to leverage and demonstrate that? And how can they be providing really great care if they maybe don't have a quality program in place? And so that's some of the foundational importance of the MBQIP program. I don't want to spend a lot of time here. I know that this is something that Becky covers, and I know that either she or I are available to answer any questions that you may come up against. As far as MBQIP is concerned, it's divided into 4 domains. We have patient safety and inpatient measures, patient engagement measures, care transition measures, and outpatient measures. These measures have changed drastically over time as the program has progressed. In some cases, measures have been removed because it was time to remove them because critical access hospitals were doing well on the measures. In many cases, they were removed because the CMS removed the measures from their programs because they had determined that performance had been topped out. This is an important distinction. Performance might be topped out in the eyes of CMS based on performance among PPS hospitals. In many cases, measures that have been removed from MBQIP and no longer have a federal process to support gathering and analyzing the data still had lots of room for improvement among the critical access hospitals that were reporting the measure, let alone those that maybe weren't reporting the measure. So for those of you who have been around for a while, we used to have heart failure measures, pneumonia measures. There were at one time, there were 5 AMI and chest pain measures, a lot of different measures over the years that have been part of the MBQIP program. They had to be removed because of that goal for FOHP to align their measurement with federal programs, but that doesn't mean that there wasn't still room for improvement. And so what we encourage hospitals to do and think about is, once you've established your processes for being able to track performance on these measures internally, we would encourage you to continue to do that for those measures where you have opportunities for improvement. Just because it's not a part of MBQIP doesn't mean it isn't important. The goal of MBQIP is to set a baseline for what is the bare minimum of measures that you are tracking on and reporting on for participation in this program, but then through that measure reporting and tracking to develop the skills to be able to analyze the data and implement improvement initiatives to drive better outcomes. Those skills around data analysis and improvement initiatives and quality improvement projects are applicable to much more than what you see on the screen here. So what we currently have Three measures in the patient safety and inpatient realm. A couple of them are related to, or one of them is healthcare influenza immunization for your healthcare providers. Another is the implementation of the core elements of antibiotic stewardship. Those are both reported through the National Healthcare Safety Network. ED2 is the admit to departure time for patients who are seen in the emergency department and then admitted to your facility. That measure will actually be removed by CMS after Q4 2019 data is submitted. Patient engagement is completely comprised of the HCAP survey, or the Hospital Consumer Assessment of Healthcare Providers and Systems. For care transitions, there's the Emergency Department Transfer Communication Measure, which is the only measure that is not collected either through CMS or NHSN. That's a measure that you submit to your state flex program. And then in the outpatient realm, there are a couple of AMI measures that remain and a couple of ED throughput measures that remain, looking at patients who are seen in the emergency department and discharged from the emergency department, or those that come in and aren't seen, they leave without being seen. This is a slide that really just tries to break down where does all of the data go. So there's this, that the previous slide kind of makes it look nice and simple. There's 4 domains, here's the measures, but the measures have to go a variety of places, and that can look different depending on your facility, depending on if you're a part of a system, depending on if you have a vendor. But essentially, a bulk of the data is submitted through QualityNet, which is the CMS data warehouse. There are a couple of measures that are currently submitted through the National Healthcare Safety Network. That's the data warehouse for the Centers for Disease Control and Prevention. And then your emergency department transfer communication data is submitted to your state flex coordinator. I want to stop there real quick to see if there's any questions at all about the basics of MBQIP or the importance of MBQIP before we dive into kind of a quality improvement 101.
Sarah, this is Becky, and you might remind everyone of the changes in the ED transfer communication measures and the education that's going on right now.
Absolutely, yes. So the emergency department transfer communication measure is one that's near and dear to Stratis's heart. Long before I came to Stratis, they did a pilot and actually were part of the group that kind of stewarded that measure, which actually the measure steward is the University of Minnesota, but we work closely with them. About a year and a half, going on 2 years ago now, we convened a technical expert panel to review that measure. What EDTC looks at is patients who are seen in your emergency department and then transferred to another facility. What is the basic core information that needs to go with that patient to the facility where they are going to be cared for? So that could mean that they are going to a tertiary facility for further care. It could mean that they're going back to the nursing home that they came from, but someone at that nursing home is going to be responsible for their care. It's essentially making sure that the receiving facility knows what happened while that patient was in your care in the emergency department. So when it was initially developed, electronic health records were much more rare, particularly in rural areas. So now they decided it was time to take a step back and look at it again. And what they did was they simplified it pretty significantly. We're down to 8 elements that are part of the measure itself. And that revised version of EDTC will go into effect starting with encounters in the emergency department January 1, 2020. So you are still in Q4 of 2019. Your data for Q4 of 2019 won't be due until sometime in early 2020, depending on your state requirements. When you start collecting your data from January 1, 2020 through March 31st, that's when you'll want to use the revised EDTC specs. There are some training opportunities underway right now. We've just convened our second of 3 national webinars that were scheduled to support folks with that transition, and also just do a back to basics review of what the measure is. There's been a lot of confusion around EDTC over the years, particularly with regards to the population. I mentioned that patients that go to the nursing home need to be included. Many people consider that a discharge home, and so they haven't been including those patients in the population. We really want you to think of the EDTC measure as patients who are going from the emergency department to another location where someone else is going to be responsible for their care. What information do those providers need in order to be able to provide safe and competent care to their patients? So if you have questions about the EDTC changes, please let me know. I can definitely navigate out to those pages as we get through things today as well.
The other thing that I might mention is that there's a group of hospitals in Indiana that no longer have Microsoft Excel available to them, and Stratis Health is working on that issue, so more to come related to that, and we'll connect with all of those organizations. So,
Yeah.
Thanks, Sarah.
Yeah, thank you, Becky. Okay, so I wanted to just provide kind of a quick level quality improvement 101. As Becky mentioned, you have some new staff and roles at your critical access hospitals, and so we're just going to kind of take a step back and talk about, we understand the importance of MBQIP, but how do we go about actually using the information that we gain from MBQIP or from other quality initiatives that we're involved in where we have data and utilize that data to drive improvement. So first we have to come to some agreement on what do we mean when we talk about quality improvement. And this is just one definition, but in healthcare, quality improvement is defined as a structured organizational process for involving personnel in planning and executing a continuous flow of improvements to provide quality healthcare that meets or exceeds expectations. So a couple of key points that we want to call out in this definition and that we'll talk about. It's structured and organized. It is a process. It's not just willy-nilly throwing noodles, spaghetti noodles against the wall, which often I feel like I do in my life. But when it comes to quality improvement, we really need to have a planned, structured process. It involves personnel, so it's not just one person. You as the quality director or manager at your critical access hospital might have in your job description that you're responsible for quality. Quality is everyone's responsibility, and you really takes a team effort to get quality improvement done. The goal is that it's continuous. So just because you implement a process doesn't mean you don't come back and analyze performance and see how that process is working. You can't just one and done when it comes to quality improvement. It is a continuous process. And the goal is to provide quality healthcare that meets or exceeds expectations. So you need to have some goals, some benchmarking in place, and really be able to analyze what your performance looks like in order to drive quality improvement. Really what quality improvement does is help us to bridge the gap between what we know, which could be based on research or identified best practices, and what we do in terms of the actual care that we deliver. So we know that we're constantly learning in healthcare new and better ways to improve the health of the population and delivering care to our individuals that we care for, but there's almost always a gap in translating knowledge to practice, and closing the gap is the role of quality improvement. So another thing that this diagram can demonstrate is that the gap might be less or narrower at the bottom, where rapid, simple changes to our processes and practices can lead to the needed change. But toward the top, we could find larger differences in how we practice and improve patient health. And then the need for change and application of quality improvement may be greater. For example, one example that we use is only 50% of hospital patients currently receive appropriate care for severe sepsis and septic shock. That's a pretty big gap, only 50%. So that's going to take a lot more resources and a lot more time intensiveness and probably more rapid tests of change and different cycles to get to a solution, whereas those that are maybe closer to the bottom might be quicker wins. And so part of quality improvement is identifying projects and prioritizing projects that help you meet both. You don't want to choose all of the ones that have huge gaps at the top or all of the ones that are quick wins at the bottom. You want to have a good mix. Having a good mix of projects that are quick wins will help to engage your team and keep them motivated and feeling good. But you also want to make sure that you're identifying and working on those ones where there are big gaps in knowledge and practice, so that we can make sure that we are really impacting patient care in a meaningful way. So when we think about the foundations of quality improvement, we've really broken it down into 4 areas. It's customer and patient focused, it's process oriented, it's a team effort, it's data driven. And if you think back to that definition and the key points that I called out from the definition of quality improvement, these 4 themes are found within that definition. So we'll walk through them just one by one. So it's customer focused. What does that mean? Often in healthcare, when we think about customers, we think about patients, and that's absolutely true. Patients are your customers. But when you work in a healthcare environment, you also have internal customers. So you want to be thinking not just about your patients, not just about families, but also who are your internal customers. So you as the quality department aren't necessarily providing care to patients, but you are providing resources and data and information to the departments that do provide care to patients. Therefore, those are your customers when you're in quality improvement. So just kind of thinking about it from that perspective might be helpful. You want to think about what does it take to delight customers. So thinking back to that definition that we reviewed, we talked about healthcare that meets or exceeds expectations. What is it that really will allow you, what is it that your patients are looking for? What do they want when they come to you? What do your customers want when they come to you? And how can you really delight them? It's also helpful to think about how can you help your coworkers see how their work affects others in the process. So sometimes, everybody came into healthcare. That's what's great about working in healthcare. People are in healthcare because they care. That's what they have a passion for it. They have a desire to serve others. So sometimes we just need a gentle reminder that that's why we're here. Sometimes we can get caught up in the day-to-day. And so sometimes helping your team approach quality improvement, that's one of the ingredients that's really going to help in your efforts. Quality improvement is process-oriented. Everything we do is a process, and a process is any sequence of events that produces a desired product or outcome. I have a background in organization development. I don't know if anyone else will recognize the name of Deming, but Deming stated that 85% of quality problems can be traced back to a process or a system problem. So what we have to do is people are really important. People are who get the work done. But when it comes to quality improvement, we want to take the people out of the equation and develop processes that allow people to do safe, effective, quality work. And so what happens when you have a well-defined process is that you reduce variation. It doesn't matter if you do it or if I do it or if Becky does it. If it's a well-defined process, we should reduce variation. So it shouldn't matter if I'm a patient being seen on the night shift or a patient being seen on the day shift, or if the charge nurse is caring for me. If the process is developed appropriately and we kind of take that human factors engineering approach and think about how can we reduce variation and make it easy for people to do the right thing. It's a team effort. So quality improvement, again, requires participation from all the stakeholders that act on a process. Individuals contribute, but quality improvement requires team involvement. So in order to reduce that variation, you don't want just one person developing the process. You want buy-in from a variety of people who maybe have seen things from different perspectives. So I'll go back to the night versus day shift example again. I, as a patient, shouldn't experience variation in the care that I receive based on whether I'm being cared for at night or during the day. But there may be factors that need to be considered from a caregiver perspective to ensure that my experience of care is consistent regardless of the time of day. So when you're building a new process, you want the night shift involved. You want them to be able to weigh in and say, well, here's why this is different at this time of night, or here's what you need to consider from our perspective in order to ensure that there is as little variation as possible in the process. And it's really important that when you're building a team that you have leadership and that stakeholder involvement as well. So you want to be able to say from the front line to the C-suite that everyone's on board with whatever the quality initiatives look like. That doesn't mean that there's C-suite involvement in every meeting of every quality initiative, but if you don't have backing from leadership, it's going to be more difficult to implement a process. And if you don't have support from the frontline staff who are responsible for carrying it out, it's not going to succeed either. And quality improvement is data driven. So data is really, again, the cornerstone of quality improvement. I said it before, if you can't measure it, you can't improve it. What data does is helps describe how the current system's working. It demonstrates what happens when you apply changes. It helps identify what variations exist in a process, monitor those processes over time, and allows you to document successful performance. Identifying successes is a huge part of quality improvement. when your team succeeds, it's really important that you reward that and that you recognize that and are able to help them celebrate their successes so that then they're on board for whatever the next project entails. So having that data to be able to show here's where we were way back when and here's where we are now is a really meaningful way to be able to demonstrate or to show that success. Some tips for practice with regards to quality improvement. I'm a broken record. If you can't measure it, you can't improve it. It's really important that you're measuring and documenting, and then that the data is transparent. So if you as the quality department have the data and it's not being shared with others in the organization, not a lot's going to happen. If you are, whether well-intentioned, however well-intentioned, if you're hoarding the data, maybe because you don't want to overwhelm or anything like that, you want to make sure that people have access to the data that they need in order to drive their processes. So many hospitals have taken to having performance boards that are published. In some hospitals, it's a requirement that all departments identify their top however many goals, or that they have a goal every month or whatever that looks like, and that data is readily available and as real time as possible. So that's that third process bullet there, put the right data in the right hands at the right time. We know that one of the big pitfalls of MBQIP and other federal quality reporting programs is that the data is dated. You don't get your data back for months and months on end. You're not even required to submit your data until months after the encounters happened, let alone get the data back. So in the meantime, it's your data. You have it. So find ways to analyze and share your internal data, and then use the external data that you receive back as a way to help you benchmark and identify your goals. Again, you want to really focus on managing processes and not healthcare providers. And this comes to an idea of just culture and identifying, again, noting that people get into healthcare because they're passionate about caring for others. They're trying to do the right thing. If a process breaks down, it's not an individual person's fault that happens, it's the system. And so what we really want to focus on is developing processes and systems that support healthcare providers in doing what it is they want to do, which is providing the best care possible for their patients. And then you really want to engage the people who do and understand the work. Again, that means your frontline staff. That means anyone who's involved in the provision of care. We've seen some really cool things happen since the advent of HCAP. So when you think about before HCAPs, patient experience surveys and the types of questions that were asked, and now with HCAPs, the engagement of kind of non-traditional staff members in driving HCAPs improvement, people like those who work in environmental services, dietary, lab, they maybe weren't ever expected or really empowered to understand their role in the patient experience. But now with the survey questions that are part of HCAPs, not only are they involved in HCAPs, but we're seeing that now that engagement is being leveraged in other areas of care as well, which is, I think, really really cool that, again, quality is everyone's responsibility. It's not just your job as the quality manager. Everybody has a responsibility for it. So some of the supports for effective quality improvement, it's really important that your organization has leadership that supports learning. So you want to be working towards creating a culture to support quality improvement, and that begins with your leadership. Empowering and supportive leadership is associated with greater acceptance and implementation of quality improvement. It's important that QI isn't viewed as an add-on, it's how you do your work. And when you can demonstrate that from the top down, it has a really meaningful impact. Similarly, you want a culture that embraces organizational change. So leadership can play a role in setting the tone and example that adopts and values organizational change. It's not that it's top down or that it's mandated change, but grassroots thinking and the promoting of and generation of ideas to improve processes comes directly from those who do the work. It requires systems thinking, which I've said a few times now, systems that are made up of those interconnected components like people, equipment, environment, and processes. And when you have systems thinking, you recognize that everything is connected, and when a change is made in one place, it can cause changes everywhere else. So you really need to think about the entire system in order to anticipate the broader impact of any change that you'll be implementing. Another example of this where we involve other departments is when you think about emergency department throughput. You have patients coming into the ED and you want to get them cared for in a proper manner, but move them through the emergency department as quickly as possible. If the ED is not the appropriate setting for them, getting them to where they need to go. If it is the appropriate setting, getting them cared for and getting them on their way. You really need to think about how are you engaging other ancillary units in that care. So what's the turnaround time for lab? What's the turnaround time for imaging? Those types of things. Systems thinking is really important. What they do there highly impacts what you are able to accomplish in the emergency department. You want an organization that supports fairness and accountability. So when you really balance that fairness and accountability, that also ties into that idea of a just culture. It creates a fair and open environment where there's understanding that the system impacts human behavior and performance. So the system drives what we do as people. Problems can often be traced back to how we've designed our systems and processes, and there needs to be fairness and accountability when we look to correct those problems. And I'll leave that one there, and I'm going to show you some resources that we have available that kind of delve into that a bit deeper. You want to be engaging customers, which includes patients and staff. So that, again, is a key concept here. You need to know who your customers are and involve them in your quality improvement efforts. So we talked a little bit about, as a quality department, your customers are both your patients and your staff, and we talked about the importance of engaging staff. It's also important to engage your customers. So when you're looking at processes and trying to identify what is it that your patients want, who better to ask than your patients? So if you don't have a patient family advisory council available either at your hospital or at a partner organization like a clinic, that's a great way to start to gather that input. You do receive your patient survey feedback, and so you can also utilize that as a way to start to look into that. And then again, you want to be using structured methods to make improvements. So in order to ensure that you continue to have buy-in from staff, you want to establish a process and a terminology and a language that is consistent so that when you're talking about quality improvement, everybody knows what you're talking about. There are a lot of different methods and approaches to quality improvement, and there isn't one right one or one wrong one. But what's important is that your facility knows what their method is and consistently and standardly applies it. So one that we talk about frequently is the Plan, Do, Study, Act model, or PDSA, sometimes PDCA, and the model for improvement, which come out of the Institute for Healthcare Improvement. So I mentioned that I'm going to talk through some resources. Some of the slides that we reviewed today actually come from the initial module of what we developed as the Quality Improvement Basics course. And so I'm going to close out of the slides here in just a moment and show you what that course entails. It's 11 modules. One of them is an overview module of the entire course, so really 10 content modules that walk you through step-by-step how to go about implementing quality improvement. It's very high level. Although it is available to the general public, it was developed specifically with a rural audience in mind, knowing that many of you wear multiple hats and have competing priorities, and so we wanted to make it as accessible as possible. It includes recordings of PowerPoint presentations that kind of walk you through what the concepts are, and then also includes tools and templates that are ready-made and that you can download and use immediately. We also have the Critical Access Hospital Quality Improvement Implementation Guide and Toolkit. I'm going to walk through this in a moment as well. This is a non-video provision of kind of similar content. So it's in a guide format. With that, there are, again, a number of templates and tools that you can utilize. And there's also some best practices or suggested strategies for quality improvement specific to the MBQIP measures. So if you've been able to participate in the last couple webinars that I've done with you all, we've reviewed some of those suggested strategies for the MBQIP measures. This is where you would find all of them in one place. Arquita and Stratis Health develop a monthly newsletter called MBQIP Monthly, and in there we have some standard articles that we have every month. One of those is a COSCAN Rural Success article. So what we do is we identify high-performing critical access hospitals across the country based on their performance in MBQIP or on a specific measure of interest. The last couple of months, we've done some antibiotic stewardship profiles of high-performing critical access hospitals in that realm. And we interview them, and then we put together a profile so that you can learn from your peers across the country as to what they're doing to drive quality improvement and performance at their facilities. And finally, these are just 3 of the resources that we've developed at Stratis Health and as part of the Rural Quality Improvement Technical Assistance Project. But there are a myriad of resources available out. If you Google quality improvement in healthcare, you will quickly become overwhelmed, or I do at least. So what we did was we developed this quality improvement basics collection of helpful resources for rural healthcare organizations. And it's just a few pages and really concisely tries to tell you what we think are the kind of cream of the crop resources that are available out there, or the most widely used resources that are available, and kind of what they entail and why you might want to use them. So I want to kind of walk you through these resources quickly. All of the resources that we developed to support MBQIP are hosted on the National Rural Health Resource Center's website. If you were to Google MBQIP, I believe that this website is the first one that would come up for you, but they have a really nice search engine. And when you navigate out to their website, which is ruralcenter.org, you can use their search engine to search, and it's actually has a nice functionality there. So what I've done is I've pulled up the 4 resources that we referenced: the Quality Improvement Basics course, the Quality Improvement Implementation Guide and Toolkit for Critical Access Hospitals, MBQIP Monthly, and the Quality Improvement Basics collection of helpful resources. The Quality Improvement Basics course is actually hosted on the Stratis Health website. So when I click on the link here, it's going to open and take me to the Stratis Health website. Here you can see that this is a breakdown of the 11 module course. So there's an overview module, 9 minutes in length for the video if you want to learn more about what this course is. The way that it was designed is that each of the modules can be standalone, or you could watch them in succession and build off of each other. So if you are really truly only interested at this point in learning, for example, about process mapping, you could jump straight to the process mapping video and watch that. If you're kind of just getting started, we encourage you to take some time and work your way through the entire course. So each of the modules has a recording. Each module also has the slides that go along with it. And then along the right-hand side and throughout the rest of the page, you'll see that there are quality improvement templates and tools. Some modules have them, some don't, but they're all captured in this box over here on the right, or they're provided in context for the module that they go along with. So this is one resource that's available to you as you're getting started on quality improvement. The final module, pulling it all together, is the lengthiest of the 11. It's 46 minutes. Most of these are 20 to 25 minutes or less. A couple are about 30 minutes. This one's longer. It really does walk through an example where you're pulling together all of the different content that's been covered throughout the course. The second one that I want to review with you real quick is this Quality Improvement Implementation Guide and Toolkit for Critical Access Hospitals. The toolkit itself is a PDF document. It's 17 pages in length, but most of that, I believe, is appendices. So you actually could it's probably closer to about 10 pages of content. And it kind of walks through, if you don't have a quality improvement program, or if you're looking at kind of revamping it, what are some suggested strategies or things that you might be able to do that? And then in here, the second link here is the quality improvement measure summaries for MBQIP. This is where you could click and find those best practices for the MBQIP measures broken down by domain, measure by measure. So it will actually take you through HCAHPS Composite 1, HCAHPS Composite 2, influenza immunization for healthcare providers. What are the suggested strategies for improving when you've identified that that's what you want to work on? There's a variety of other tools that are available here. Descriptions of all of these tools are embedded within the guide. So as you read through the guide, you'll find links to take you to each of these tools as well. And one that I find really helpful is the prioritization tool. We know you're working on much more than just the measures from MBQIP, so this is a way to help you kind of not boil the ocean. What are your top priorities, and how can you be really kind of thoughtful about how you prioritize them, not just picking willy-nilly. Again, thinking of that image that I shared at the beginning about finding the gap between knowledge and practice. How can you find different priorities along that gamut? MBQIP Monthly is our newsletter. All of our MBQIP Monthly newsletters can be found here. I can scroll and go back and find literally all of them that have been posted. So if you're interested in reading stories about others in the field and what they're doing, this is a great spot for that. And then finally, the Quality Improvement Basics collection here is available, and I'll just open that real quickly so that you can see what that looks like. It is a PDF resource that, oh, sorry about that, I have some other things open here, that walks you through some different quality improvement resources that are available, including the Institute for Healthcare Improvement, AHRQ at the Agency for Healthcare and Research and Quality, the ONC. There's a lot of different resources available here. What we tried to do is in 5 pages just kind of synthesize all of the things that we frequently reference from our vantage point as a quality improvement provider. All right, I went a little bit over. How are we doing, Becky?
Oh, you're doing fine. You're doing
okay.
fine.
All right, great. So that was really what I had for you today, was to provide that kind of quality improvement 101 and review a few of those resources for you all. Are there questions, comments, suggestions?
And this is just part 1 of a 2-part session. The next session will be in January. We are recording the session today, and when I send out the link to the recording, I'm also going to include the MBQIP measures document. It's a 2-page document. On page 1 is all of the required measures for MBQIP, and on page 2 are some optional measures. And from the State Office of Rural Health perspective, we've been really focusing in on some of the HAI and the swing bed measures. So that's where some of those efforts have come from. Please watch the monthly updates as well. There's some opportunities to join some calls that are related to abstraction accuracy, and some office hours that if you have questions related to abstraction. But I highly recommend that you share internally these links to these quality improvement strategies that Sarah has just reviewed with you, perhaps sharing with directors and some of the informal leaders on your staff. The recordings are very nice and really cover each of those particular topics well. So likewise, if you're wanting some additional support and education, those that are newer to quality and you have not used QualityNet, often contact me and I can set up an individual session to go through QualityNet, make sure that you are signed up for the appropriate list discussion groups, and also to kind of take a deeper dive into Hospital Compare and just really learning exactly what's out there on Hospital Compare. And there are even some benchmarking information that's available to you and some good descriptions on what's included. And Sarah, one question that did come in was there had been some discussions in the past regarding having a critical access Hospital Compare website. Is there any update to that?
So at this point, I'm not aware of any. I know that one of the things that critical access hospitals have struggled with is not having a star rating calculated on their behalf, and that's one of the functions of the Hospital Compare currently. Hopefully you all know that your data that you submit to CMS is posted on Hospital Compare as long as it meets volume threshold requirements and you haven't opted to suppress the data. That's been a change over time, but now all of that data should be made publicly available. There has been discussion, and we are working on a way of being able to kind of let critical access hospitals know how they're doing overall on MBQIP, a sort of roll-up or composite of that in its own right. Now that's specific to the measures for MBQIP, and there hasn't been any discussion about necessarily, though it's been suggested, we haven't gotten to the point where we've been able to talk about what would it look like to make that public. But it will be available to critical access, to state flex programs, and through them to critical access hospitals within the next year or so. That's called, currently being referred to as the MBQIP performance standards. So it's a way of looking at all of the hospitals that are meeting the minimum reporting requirements, how are they actually doing on the measures, and then ranking them kind of based on that. But there isn't, to my knowledge, any discussion from CMS, who hosts the Hospital Compare, to do anything specific to rural providers.
Okay. The other question that was chatted privately to me was, are there any videos available to help with measure development internally?
Oh, that's interesting. So what I would encourage that person to do is let us know what type of measures you're interested in. So it's really going to depend on what you're looking at developing. In many cases, you don't have to recreate that wheel. It's been created for you.
Okay. The two that came to me were outcome and balancing measures.
Oh, sure. Yes. So the Institute for Healthcare Improvement does a really nice job. I'm going to go back to the QI resources collection here. IHI does a really nice job in their open school of walking you through what it looks like to develop meaningful measures. And they look at process, outcome, and balance measures in their measure development. So if you haven't gone through their open school, there is a cost associated with it, and it depends on how many folks you want to be able to go through it. But IHI is really a great resource for all things healthcare quality improvement related, including measurement.
Great, great. That's all the questions that I've received. So if there are others, and as you're developing your quality initiatives internally and need assistance, why please reach out to me, Becky Royer, and I will provide some guidance and assistance. And if you have additional questions for Sarah, why certainly email those to me and I will facilitate getting an answer. So thank you so much, Sarah. You've done a great job sharing a lot of information. And again, part 2 of the quality improvement series will be in January. Be sending out more information on that at a later time. And we wish everyone a happy holiday and Merry Christmas, and look for a great start to 2020. So thank you all for joining today.